I'm delighted to introduce the next speaker, Professor Alexander Wahba. He's a consultant cardiothoracic surgery, Trondheim University Hospital, Norway, and he's a professor of thoracic surgery in Norwegian University of Science and Technology, Trondheim. He's affiliate professor in cardiac surgery at Umeå University in Sweden, and he stands as the chairman of the European Board of Cardiovascular Perfusion. He will talk about resuming to elective cardiac surgery in a dedicated COVID-19 hospital. How, when, and for which patients? Please, Alex.
Thank you very much, Mohamed, for your kind introduction. First, I would like to explain to you the situation as we experienced it in Norway, because the situation was different from several other countries. Here you can see our hospital, which is the biggest regional hospital with about 700 beds. And the cardiac surgical unit is down here close to the river. We are doing about 500 cardiac cases every year and about 300 thoracic cases. So we have a fair workload, which is the normal workload. Here you can see that in Norway, we have a population of 5.4 million, and you see the number of infections up to the 28th of May here. 236 patients died of COVID-19. We had a lockdown very early in the course of the pandemic. Our lockdown was on the 12th of March, and we only had very few patients at that time. In our hospital, we had 2 patients admitted to the ward, and we had no patient on ICU at that moment. When the country was locked down, we all had home office to attend to. All schools were closed, all kindergartens were closed, and we had a very strict social distancing policy. However, the shops remained open and we were allowed to go outside. There was no curfew at any time. Now, of course, the situation in Norway for most part of the country is that the population is not so dense, so there was no need to have a curfew. The measures were in place for several weeks. Now here you can see the situation in our region, which is Trøndelag region. You can see that on the 12th of March, when the country was locked down, we had about 4 to 5 patients every day with COVID-19. Over the next few days, the number of patients increased, but then it went down very fast. And here on the right-hand side, you see the cumulative number of patients. So we have in our region reached a number of patients of about 500. Of course, most of them are now healthy again. In this slide, you see the number of admissions at our hospital and daily admissions. And you see that ICU, which is the red line, we had our first ICU patient on the 22nd of March, and we never had more than 3 patients at the same time. So during the pandemic, we prepared, or after the lockdown, we prepared for a great number of ICU beds, and in the hospital, a total of 100 beds, ICU beds, was prepared. But of course, we never had to do that. At that time, we stopped all elective work. We closed the hospital. Visitors were not allowed. Our main ICU was divided into 2 separate ICUs. One of them was dealing with the normal work, and the other ICU was only COVID-19 ICU. As I said, we made plans for a massive admission of COVID-19 patients, but we never had to actually implement these plans. We also had a travel ban for all employees. That means we're not allowed to go abroad. One good thing that we had good experience with was the centralized management of personal protective equipment in Norway. That means not the individual hospital was dealing with supplies. There was a central supply and the supplies were going to the hospitals that needed it most. Now, what we did in our unit was we postponed elective surgery, particularly high-risk surgery, for example, arch surgery, thoracoabdominal aneurysms, double valve replacements. But we still did all emergencies, of course, and we also did all unstable patients. So that means we mainly did coronary operations for patients that were admitted to hospital and that could not be sent home. Also, we did all lung cancer operations because they were deemed important enough to continue to do that. Of course, that would have been different if we had admitted hundreds of COVID-19 patients. We would have reduced this activity. But in total, we halved our usual caseload. So we were at about 50% of what we normally do. Now, here you can see a very important phenomenon that most countries experienced, that emergencies like strokes and myocardial infarctions went down considerably. Normally, we would have 150 myocardial infarctions per month, and during the COVID-19 pandemic, we only had about 100. Also, strokes were going down a lot during that phase. So certainly you could say we had less emergencies than normally, and we had less acute coronary cases. But as I said, in total, we did 50%. So the main problem with returning to elective surgery after several weeks of lockdown was the lack of personal protective equipment. We had enough equipment to deal with the daily needs, but we were always holding back equipment to have enough in case many COVID-19 patients would come. Also, we had a problem with ICU capacity because half of the ICU was a dedicated COVID-19 ICU, although we did have almost no patients. We also saw that there was an increased risk of closing wards and departments in case staff would get infected. So we were very careful with starting up elective surgery so that we don't get in that situation. Now, the patients that I think that should be operated on first, of course, is coronary patients with good left ventricular function. And as you know, in many hospitals, these patients, they don't stay overnight on ICU. That means most of these patients will be out of ICU by the end of the day. And then that means that does not put strong pressure on the ICU system. Also, isolated valve surgeries are a good way to start elective surgery. So we also would like to point out that the biggest problem in the whole phase with respect to ICU beds, of course, were emergencies that you have to operate anyway. So the elective cases, they will not put so much pressure on the system. So ICU beds was not our main concern, but of course, we had to be careful with the amount of personnel that we had, and we had to increase slowly. In total, we increased our elective amount of operations over a period of 3 weeks. After these 3 weeks, we were fully up and did operate as many as normal. And this we have been doing for about 4 weeks now. One of the important points is, as I said,